So, antenatal care. We continue with our lectures on obstetrics and gynecology. Um, the antenatal care, commonly known as ANC, is a comprehensive health care. It involves provision of a pregnant woman to maintain and protect her physical and emotional well-being and that of the fetus. The care is given to the pregnant woman from the diagnosis of pregnancy to birth. It aims at well-being of the mother and the fetus by recognizing and management or the referral of any problems identified. The objectives of antenatal clinic involve to maintain the mother in health of body and mind, to identify unmet needs in nutrition, to prevent and treat complications in pregnancy, to anticipate difficulties and complications of labor, to ensure the path of a healthy infant, to help the mother to rear the child, educate on the child care, hygiene, and breastfeeding, to establish contact and promote understanding between the woman and those who will look after her in pregnancy and labor. So objectively, you want to see, is the mother okay? Physical health and mental health. Is there any complications? You treat them. You anticipate for any difficulties and complications of labor. And this one, you sort them out. You ensure the path of a healthy infant. You help the mother to bring up the child in the home in a good way. So what's ANC? An objective monitoring and supervision care in pregnancy to maintain and protect the physical well-being and the mind of the baby and the mother. Now, the attributes of ANC, it must be accessible financially, geographically, and time. It's near, it's available, it should be there. Then it must be acceptable. The culture, the safety should be humane, and then should be affordable. Sometimes affordability is looked at accessibility financially. Yes, it's available near geographically, but can we afford? So it should be available, should be affordable, should be accessible in very many ways. Now we have three major approaches in antenatal clinic or antenatal care clinic approaches. So we have the traditional, we have the focused, and we have high risk approach. So all these have been put in play, and most different countries use different methods or approaches in the antenatal clinic. Under the traditional care or the ANC clinic, when should it begin? When should we think of beginning the ANC? But before then, you need to do pre-pregnancy counseling. Usually it's advised before someone decides or thinks of becoming or to conceive, they need to see an obstetrician, gynecologist. This one gives them a pre-pregnancy counseling. So you begin with the NC care, beginning before pregnancy. The woman's health should be in its best possible state before embarking on pregnancy. DOM before pregnancy. Advice on avoidance of alcohol and smoking, teratogens. Advice on dietary, smoking and alcohol drinking habits. Women who are sick and those with special problems and anxieties, they need to be helped. What should they? They need to conceive. You need to help them to have proper decision making and informed consent. Now, in conduction of the antenatal care, the coverage is in Africa, for example, is a success story. Since over two-thirds of pregnant women, 69%, have at least one ANC contact. We want to see the difference between a contact and a visit. Between these, the various approaches that we've talked about. So we have the traditional, the focused antenatal care, the 2016 WHO ANC model, high-risk approach, or specialized care. Of these approaches, we've spoken about the three, but again, we have the model of World Health Organization, ANC model. Now, let us begin looking one by one. What does the traditional ANC approach say about women looking for care pre-pregnancy, intra-pregnancy, up to birth? So you just need to have first visit as soon as pregnancy is confirmed. Then you visit monthly up to 28 weeks. Then fortnight up to 36 weeks. Then weekly up to labor and delivery. So if the first one is on first confirmation of pregnancy, then you come every month for 28 weeks. So 28 weeks, it has 4 months, or 4 months. No, 7 months. Is 7 months, right? So here you shall have come around 7 times. So plus this one. And then fortnight up to 36 weeks. So 2 weekly, and then weekly up to labor and delivery. So it used to be very tedious, and some countries have adopted the traditional ANC approach. So there is a lot of visits. The first one, when you've confirmed pregnancy, and then monthly up to 28 weeks, then 2 weekly up to that 6 weeks, and then weekly up to labor and delivery. What about the focused antenatal care? So there's a lot of discussions about, should we do traditional approach or should we do focused antenatal care? Now, for focused antenatal care, some scholars were arguing it's a lot of visits you make to the clinic. Around 1 plus 7 plus, these are how many weeks here? These are how many months? This 1, 2, around 2, you come plus 2, and then plus, if your term is 37, 38, 39, or 40, depending, it was a lot, totaling to around 10 visits. So for the forecast, usually called FANC, is divided into 4 visits. So the first visit is before 12 weeks, before quickening of the baby. And then the second visit is around 26 weeks. Then the third should be around 32. Then the fourth visit is at 36 to 38 weeks. That part, of course. So we have 4 forecast. We have forecast. So this one is to achieve the full life-saving potential that ANC promises for women. And then the aim is to, and the advantage is to save the patient's time and money and travel. It promotes better doctor-patient relationships, individualizing care by reducing the number of patients attending hospital clinics. So it saves money, travel, time, and patients resources. Then it promotes the doctor-patient relationship. Any abnormality will demand further investigations, of course. What about the 2016 WHO model? So it involves specific evidence-based interventions for all women, carried out at 4 critical times. It's also known as focused antenatal care model, part of pregnancy, childbirth, postpartum, and newborn care is also there. So it's more of a funk, but this is some revision here. You look at it, the first trimester, first visit, 8 to 12 weeks. And then the contact is 1. So contact here means when you come to visit the clinic. Then the second trimester, you visit the clinic at 24 to 26 weeks. So you can have the second contact and the third contact on 20th week and the 26th week. So you can have 2. Second trimester, you can have 2 contacts. First trimester, you have 1 contact. And in the third trimester, visit around 32 weeks, visit and around 36 to 38 weeks. So the contact can be at 30, 34, 36, 38, 40. So you see the spacing here. It's between 4 weeks and then 2 weeks. So the visits return for delivery at 41 weeks if not given birth. Of course, we said beyond 41 weeks is post-date. Below that 7 weeks is premature delivery. So this is the model they gave. Is a focused antenatal care, is kind of a revised funk, focused antenatal care. So there is a difference between contact and visit, as we've said. A contact implies an active connection between a pregnant woman and a healthcare provider. It's not implicit with the word visit. When you're visiting, you just come. And then you might not have a lot to do because usually visits are so traditional, they're so regular. But contact, it's spaced, the focus is focused. And then it is in the context of intervention, giving services to the mother seeking them. So the initial contact should be usually below 12 weeks or at 12 weeks. Then there's initial contact, the mandatory things you need to do. You need to do general medical history. Know that is your mother high risk? We're going to see the high risk approach, and it's going to tell us who is at high risk. And then you need to look at the age. Below 16, above 30 years is considered high risk. Then, as the pregnancy following a long period of infertility, that's high risk. After induction of ovulation, these people are still high risk. Any significant illnesses include cardiac disease, renal disease, diabetes, rubella, German measles, that is, blood transfusion, exposure to HIV, pulmonary disease such as TB, thyroid disorder, psychiatric illnesses, orthopedic problems, kyphoscoliosis, pelvic bone deformity. All these are considered to be high risk. All these are considered to be high risk. You need to take drug history, know the level of alcohol intake, cigarette smoking, survey of her general social and environmental circumstances, previous surgical treatment and gynecological operations. All these history on initial contact. Of course, the patient biodata is very important to identify whether you're dealing with a high-risk patient or not. So you need to do a family history, the history of diabetes, the history of hypertension, the family history of twinning, socioeconomic statuses, because patients belonging to low socioeconomic status, they have higher incidence of anemia, preterm labor, growth retardation, and all these. The history of congenital malformation, very, very key. Then the past obstetric history, know about the parity, know about prime gravidas, know about grand multiparity. We're going to do definitions of these things. Previous pregnancies, know the prolonged labor, instrumental delivery, fetal outcomes, and postpartum complications. Check on 2 or more previous miscarriages or previous induced labor or abortion, previous stillbirth. Check on previous birth of babies with congenital abnormality. Check on previous preterm labor, previous birth of macrosomic or small for gestational age. Check on pregnancy-induced hypertension. All these, it helps you to know whether you need to do a referral to where we have these special care clinics. On continuation of obstetric history, know the history of malpresentation. You need to know about multiple gestation. Know the history of hydromegaly, previous cesarean sections. Know the history of antepartum hemorrhage. On the 3rd stage of labor, know the abnormalities surrounding it. The 3rd stage of labor, we're going to do labor, and you're going to realize this from the time the baby is out to the time the placenta is out. So you can actually have postpartum hemorrhages, retained placentas, and this has a particular tendency to recur. Previous infant with rhesus isoimmunization. This one is also key. History of present pregnancy, the date of the first day of the last menstrual period. The woman's normal menstrual period, the length, the normal cycle, irregularities, use of contraceptions. On general examinations, it's also important. It's going to help you to know whether you are dealing with a high risk, you're dealing with the probably normal. Measurements of weight, height, blood pressure, pulse, short stature, that's below 150 centimeters, overweight, underweight, BMI. Check on these. BMI 20 to 24 is accepted as normal. Note any abnormal gait or deformities. Examine the breasts, the heart, and the lungs. The teeth are inspected for the presence of gum infection and caries. Examine the legs for the presence of varicose veins and edema and any other abnormalities. Abdominal examination, check for the height of the fundus, the presence of the fetus, the widest diameter of the fetal head, whether it has entered the brim of the pelvis. Auscultations of the fetal heart sound. Ask the mother whether she can appreciate the movement and the kicks of the baby. Then do a VE, a vaginal examination. So you will check the position of the uterus, the size in relation to the menstrual history. Any extrauterine abnormalities such as ovarian cyst, fibromyomas, these are the neoplasms of the female reproductive system, the general shape of the pelvis. Cervical smear can be taken for cytological examination. Investigations, very important. Do urinalysis, midstream specimen. Do a random blood sugar. Determine the ABO and vessels blood group. Check for hemoglobin concentration to rule out anemias. You can do hemoglobin electrophoresis to check for hemoglobinopathies. Serological test for syphilis, HIV, and hepatitis. Check for rubella, toxoplasmosis, cytomegaloviruses, herpes simplex virus, antibody screening. All these you need to check. Check for alpha fetoproteins at 16 to 18 weeks It gives a clue for neurotube defects, Down syndrome. Do an ultrasound scan at 16 weeks to confirm gestational age and to exclude any gross fetal abnormalities. These are very, very key. You check for hemoglobin, you check for cytomegalovirus, you check for toxoplasma, you check for rubella, you check for rhesus and blood group determination, random blood sugar. You can do even stool analysis. Subsequent visits, you need to do what? At every subsequent visit, the contact that we've spoken about, do blood pressure, record it, see whether it's between normal levels. This is going to give you a clue on preeclampsia, on eclampsia. Do urine test for every visit. It's very good to give you ketonurias. It's also give you a clue of preeclampsia, eclampsia. Check for weight gain assessment. At the end of pregnancy, we just need to gain around an average of 12.5 kilos cumulatively. Check for hemoglobin concentration. Estimate it again at the 30th and that 6th week. Blood sugar estimation is also good in every subsequent visits because we have gestational diabetes mellitus. Check for abdominal examination, fundal height. Check for the presentation of the fetus. Check for engagement. Check for the lie. The birth plan. Ask the mother whether there's a decision of the birthplace. Identify transport means to the center. Ensure for transport. Ensure for transport. And hospital charges. Choose a path companion. Items for delivery. Family caretaker while in hospital. So the companion, the caretaker in the hospital, the transport, the decision on the place of birth, identify the items for delivery and help them to plan. Then we have the general things for nutritional care during prenatal care. This is very important. I mean, you need to counsel about health, eating, and keeping physically active during pregnancy. It's all this recommended for pregnant women who stay healthy and they prevent excessive weight gain during pregnancy. Let the mother sit and only eat and walk around the house. No, let them have an active lifestyle while they're staying within the compound or within the working context. Undernourished population, do a nutritional education. Increasing daily energy and protein intake is recommended to reduce low birth weight neonates. It's context specific. So for the undernourished as well, ensure there is variety, balanced energy and protein dietary supplementation. This population as well, high protein supplementation is not recommended. Just gradually. Daily oral iron and folic, it's called IFAS, supplemental iron and folic acid. This one, 30 milligrams to 60 milligrams of elemental iron. Folic acid, around 400 microgram or 0.4 milligrams. It's also recommended. This one prevents neurotube defects. Intermittent oral iron and folic supplementation, context specific. 120 milligrams, you're increasing the dose. This is context specific. The population with low dietary calcium intake, talk about calcium supplementation. This is also context specific because approximately the entire world, except few, can have calcium hypocalcemia. So they need to have supplementation. Vitamin A supplementation, only recommended. This one, you need to know that excess of vitamin A is teratogenic. So it's only recommended for pregnant women in areas where vitamin A deficiency is very severe to prevent night blindness. This is context specific. And be careful when you are giving vitamin A. And then we have zinc. Talk about the zinc. For pregnant women, it's only recommended in context of rigorous research. Otherwise, don't give. Multiple micronutrient supplementation, not recommended for pregnant women. Dietary intake, we've said about it, that's enough. Pyridoxine is not recommended for pregnant women to improve maternal and perinatal outcome. Vitamin E and C, not recommended. Vitamin D, not recommended. For pregnant women with high dietary caffeine intake, more than 300 milligrams per day, lowering daily caffeine intake during pregnancy is recommended to reduce the risk of pregnancy loss and low birth weight neonates. It's context specific as well. So the counseling here is about the sexually transmitted infection. Talk about HIV. Talk about breastfeeding. How should we prevent them? Protection. What are the risks about them? Talk about syphilis. Talk about gonorrhea. All these, how are they going to affect your baby? Talk about HIV. For those who are already infected with HIV, what should we do? How should we prevent the unborn baby from contracting HIV? On what medication should you be? How long? Then how should you take them? Breastfeeding for the HIV mothers and for those who are not infected. How should we breastfeed? It's now recommended. Exclusive breastfeeding until it's not recommended, until proven otherwise. Otherwise, it should be done exclusively for 6 months. The use of contraceptive. Speak about family planning immediately before pregnancy. We said ANC begins before pregnancy. Anyone who has had a thought of conceiving, let them begin. Then the treatment of cancer and then cancer screening, all this you need to talk about. Then let the women's view of pregnancy be positive. Let them speak about the experience from ANC. Health pregnancy for mothers, physical and social cultural normally, effective transition to positive labor and birth, positive motherhood. This is very key. So when we meet next, we're going to speak about high-risk approach. Thank you. Until then, we meet.